Uh, Good morning, seniors and dear colleagues. In fact, I have been given the task to discuss about heart failure in diabetes. Heart failure in diabetes, so far as preserved ejection fraction and reduced ejection fraction is concerned. We never used to hear these two terms of preserved ejection fraction and reduced ejection fraction much before 2021. But 2021 saw a big sea change in the terminology, and heart failure treatment has taken a big leap in the last year. Now, first, when I discuss my topic, I have to discuss what do we mean by heart failure in diabetes, because we all are worried that how do we detect this heart failure? This is the first aspect of the topic that would like to be discussed. We try to see the incidence of heart failure in diabetics. It has been seen that 1 or 2 in 100 people in India may be diagnosed with heart failure. Out of the total heart failure population, 55% have diabetes. That means if you translate it, it becomes to 161,000 new heart failure patients per year due to diabetes. Although we think that it is a very small number, but in fact, for cardiologists, it's a very big number and is a very big load on the thing that is monetary aspects both for the patient and the country. Now, if we see, heart failure is one of the first manifestation of type 2 diabetes related cardiovascular disease. If you try to see the first manifestation, 14.1% of patients having a cardiovascular events, heart failure is there. And if you see all the trials, you see the type 2 diabetes trials, heart failure is prevalent 10 to 30%. If you see the chronic heart failure patients, type 2 diabetes prevalent in 30%. So that means in any way, 1/3 of the patients with diabetes will definitely have heart failure. Let us see what is the incidence of LV dysfunction or heart failure in patients with diabetes. Either there may be diastolic LV dysfunction, systolic LV dysfunction, or systolic and diastolic. It is only 32% of the patients that who do not have a dysfunction. More than 66% of the patients have some form of dysfunction, and especially the diastolic dysfunction, which is not easily detected. Also, heart failure is an early and forgotten complication type 2 diabetes, and we have to pick up this complication as early as possible. Now, why does a patient of diabetes go into heart failure? The two pathways. Number one, this reduced ejection fraction may be due to myocardial wall damage. That is, the patient may have a MI or may have other associated atherosclerotic problems. So this may be atherosclerotic mediated. The other way is that the patient may have microvascular effects which cannot be detected, but it is all a direct inflammatory effect. And because of this, these are atherosclerotic independent factors. So both atherosclerotic mediated and independent factors finally lead to heart failure. If you see the worsening of heart failure times, once you diagnose these patients with diabetes in 3 to 6 months after they're diagnosed in the OPD, and you start a guideline-directed mediated therapy, you'll see within years they start worsening much and more, and within months they go into an advanced risk where they're refractory to guideline-directed mediated therapy. So once heart failure sets in these patients, they have a very rapid onset course and they gradually decrease. And by the time they reach to the cardiologist, they're already in frank heart failure. Now, this is something interesting. What happens once this patient goes into heart failure? The most important thing is that they start having a recurrent hospitalization. And once they have recurrent hospitalization, there is a chronic decline in the cardiac function, and this affects the quality of life. Not only does it affect the quality of life, the disease does progress and mortality also increases. So it is very important to recognize these heart failure patients because they always have a downhill course. I come to the next aspect that is what is preserved ejection fraction and reduced ejection fraction. These are two definitions which we need to define, and this has been defined as per the consensus statements given in 2021. So now if I see the classification, we have on two entities, that is what is preserved ejection fraction and what is reduced ejection fraction. So this is what we have been doing since the last 1 year or 1.5 years, that we classify all these patients into preserved and reduced. Now we tell it that the patient has a reduced ejection fraction if the patient has a systolic heart failure. That is, the muscle is weak, they cannot squeeze out blood. Now, if the patient has got a thickened muscle, a stiff muscle, the LV function is normal, and the patient cannot, the muscles cannot relax properly, it is known as diastolic heart failure or preserved ejection fraction. So if you see the joint position paper of the European Journal of Heart Failure in 2021 and also the ESC guidelines, to classify a patient with heart failure, number one, they should have certain symptoms of heart failure. And number two, most importantly, they depend on the biochemical markers, that is the NT-proBNPs. So this is what the European Journal of Heart Failure stated in 2021. But the European Society of Cardiology clearly stated that you have to depend on two factors. Number one, the biochemical factors, that is the NT-proBNP and the echocardiography. If these two are present, then you can definitely say that heart failure is confirmed. And depending on the ejection fraction, you can define if it is less than 40, it is reduced. If it is more than 50, it is preserved. In between 40 to 50, it is mid-range. So this is how the new classification goes in 2021. Now, is there anything between heart failure of preserved ejection fraction, reduced ejection fraction? Yes, there is something what we call between the spectrum of the reduced ejection fraction to preserved ejection fraction. One patient of reduced ejection fraction may be started on therapy, and once you start on therapy, this patient will gradually go to preserved ejection fraction. So this is what we call in between these two ranges of reduced and preserved, there is a mid-range ejection fraction, or if a patient is going from reduced to preserved, it is known as recovering ejection fraction. So these are the four terms that we are currently using 2022, that it may be reduced, mid-range, recovered, or preserved. This is a very important study which was done in our country. It was seen that we always have the idea that patients with preserved ejection fraction have a good outcome. No, this was a tremendum heart failure registry. We showed that preserved ejection fraction patient may be having a normal LV, still then they are at higher mortality, almost equivalent to reduced ejection fraction. And they have more readmissions compared to what was in reduced ejection fraction. So nowadays, we have started realizing the importance of preserved ejection fraction. So how do we investigate and establish heart failure? The European guidelines says there's two factors that you need to know. Besides the clinical evaluation, there is an echocardiography to be done and the biochemical parameters to be done. Now, what are the echocardiographies that is to be seen? Echocardiogram, just what you have to classify is the ejection fraction. Our ejection fraction was derived by two scientists, Kennedy and Sonnenblick, who described that ejection fraction can be easily calculated in form of a percentage. And if you try to see, this is the percentage of blood pumped out by the left ventricle during each contraction. So if you go ahead, this ejection fraction, as per the universal definition coming from various societies, the American Society, the European Society, the Japanese Heart Society, they all combined together into the Chinese Heart Failure Association. They stated that anything less than 40 is reduced ejection fraction, 41 to 49 is mid-range ejection fraction, more than 50 is preserved ejection fraction. The patient of reduced ejection fraction can gradually go to preserved ejection fraction. And as I said, anything more than 40 may either be an improved ejection fraction or a mid-range ejection fraction. So these are the 5 terms which have been already defined in all societies. And even the Indian Heart Failure Association has also started accepting this form of a classification. Now, this is a case of a very diabetic who has got a very poor LV function. You can see how poor the contractility is. Now, the next factor that you have to see are the biochemical markers. There's just mainly one biochemical markers, so we have a lot of biochemical markers, and the biochemical marker are the natriuretic peptide. These natriuretic peptides are released by the heart in response to heart failure. And what basically happens when heart failure is there, there's atrial and ventricular distension or stretch occurs, neurohumoral stimuli takes place, and 3 natriuretic peptides come into the circulation, the ANP, BNP, and the CNP. Now, the ANP is the atrial natriuretic peptide, the BNP is a B-type natriuretic peptide which is secreted by the ventricles in response to volume overload, and the C-type natriuretic peptide increases during the vascular inflammation. Actions of all 3 are similar, but we mainly depend on the BNP to find out whether the patient is in heart failure. Now, what basically happens once there is a neurohumoral stimuli or insult, it causes the cardiac cells to release this pre-proBNP, and this proBNP is released, and this divides into NT-proBNP and BNP. Some labs estimate the NT-proBNP, some labs estimate the BNP. Both are acceptable as per the guidelines, and the drugs have come out that we can inhibit this and inactivate this by these neprilysin inhibitors or the ARNI, which are currently available. So this is the second modality how you diagnose your heart failure patients. Now, this has been established as a biomarker for heart failure and is easily available in all labs and should be done whenever a patient is suspected to be having heart failure. Now, this is the main target of therapy, one of the important target of therapy in heart failure these days. Let us see what the guidelines of European Society and the American Heart Association state. They all have put that NT-proBNP is the class 1 indicator so far as diagnosis is concerned. But here there is a word of caution that you have to know that NT-proBNP or proBNP is not same in all age group. If it is less than 50, it should be more than 450. Then only you diagnose heart failure. 50 to 75 years, it should be more than 900. More than 75, more than 100, 1800. Now, what usually happens, the lab says that if it is more than 123, it is heart failure. Please go by the ages. Don't tell that a patient having 450, more than 75 years has heart failure. So this is very important, and this has been clearly put in the 2017 Canadian guidelines that this should be the values as per the biochemist, and this should be mentioned in the reports also. Let us see what is the treatment for heart failure, reduced ejection fraction. I always say the heart failure is the heart is like a tired donkey. And previously, what we used to do, either we used to put digitalis, that is, put a carrot in front of this donkey so that the heart would function better. But now digitalis is almost out, except for rate control. The next that we used to do, we used to reduce the number of sacks in the cart so that the donkey would run better. And this is what we can do by using diuretics, ACE, or ARB. And this is what is also done to decongest the patient so that the heart can work faster. Now, in 2021, there was an editorial in ESC which showed the fantastic four drugs which are to be used are the MRAs, beta blockers, SGLT2 inhibitors, RNA. These are the 4 pillars for heart failure. Besides this, we know that iron is there, hydrogen nitrates for black people, there is surgical repair, there are diuretics, vericogut, digitalis, anticoagulants, CRT, evaporating. These are all drugs depending on additional drugs, depending on the condition that we have to give. But these are the 4 basic drugs that has been recommended in 2021 as per the ESC guidelines. Among these, the 2 most important drugs which have hit the headlines are the SGLT2 inhibitors and the RNA. Now, how do the SGLT2 inhibitors work? First, it was way back in 2019 that with reduced ejection fraction, DAPA heart failure showed a tremendous benefit, and they showed, and the primary author Deepak Bhatt wrote that it was a momentous victory in the war against heart failure. And these SGLT inhibitors, especially dapagliflozin, markedly reduced mortality and worsening of heart failure. In fact, it was people started telling that possibly this was a drug which could prevent heart failure. And if you see the DAPA heart failure study, this was a very large study of more than 4,000 patients. We showed that it was a 26% risk reduction compared to placebo. So far as worsening of heart failure was concerned, 30% relative risk reduction of the primary endpoint. So far as dapagliflozin was concerned, there was an 18% reduction in cardiovascular death so far as dapagliflozin was concerned. And most importantly, dapagliflozin started acting on heart failure patient within 1 month. So if you start a patient on this drug, within 1 month, you'll start seeing the results. So that is why we say it is wise to put these patients on in hospital so far as the patient started having heart failure post-MI. Then came the Emperor Reduced study. The Emperor Reduced study also showed the same results literally. That was a 25% relative risk reduction. There was a 30% reduction in the first and recurrent heart failure hospitalization, and eGFR slope also decreased. And if you compare the DAPA heart failure versus the Emperor Reduced study, the DAPA heart failure study showed the 26% reduction of CV death, hospitalizations, urgent heart failure visit, and Emperor Reduced showed that 25% reduction in time to cardiovascular death, heart failure hospitalization. So an editorial came out, possibly it was the same, there are 2 sides of the same coin, that is dapagliflozin and empagliflozin. Then came the drug in 2020, that is the sotagliflozin. Now, sotagliflozin is not available in our country. Sotagliflozin is a SGLT2 and SGLT2 inhibitor, and the SOLOIST WHF study has clearly stated that there is a significant reduction of heart failure hospitalization if sotagliflozin is used. It's a small study, And another newer drug that is coming up is the Vericogut, which has been studied and has been published, but has not yet entered our market. Then came ARNI. ARNI was tried in a lot of countries. The paradigm study where 637 patients were from India, and it showed a 20% reduction in hospitalization due to heart failure, and it was seen as early as 180 days. And most importantly, it was seen that there was a reduction in cardiovascular death by almost 20%, and it compared to an ARB and AC inhibitor, ARNI had an additional advantage of 20%. If you add and RNA as early as possible, the mortality decrease are almost to the tune of 38%. So this was something very interesting. So we had two drugs in 2021 which proved themselves, that was the SGLT2 inhibitors and RNA, which showed that these two drugs could be used in preventing or treating heart failure, reduced ejection fraction. So before 2021, we had this conventional sequencing that you start giving an ACE, then a beta blocker, then a MRA, then AR, RNA, then SGLT. Now, the proposed sequencing is start with beta blocker and SGLT inhibitor as step 1, go to RNA with step 2, and go to this thing MRI in step 3. Most importantly, what it is stated is that you have to start all these 4 drugs in 4 weeks. That is what you stand in 2022. That is, do not debar the patient. You start with RNA, start with SGLT2, start with MRA, beta blocker one by one. Complete all your 4 drugs in 4 weeks. That is, rapid sequencing of the drugs has to be done to prevent heart failure. What next? Supposing the donkey is not able to run anymore. Possibly then came the question of putting the patient on certain, like there's some machines, some devices, so that the horse can run faster. And that is where we started thinking of using device therapy, where pharmacotherapy is to fail. And various devices have come into role, that is ICDs, which reduces mortalities, CRTDs, which combine CRT with pacing, CRTPs, which combine CRT with pacing and improves the exercise capacity and survival, and lastly, left ventricular assist devices, which improve survival and improve functional capacity. And these are basically used in patients who are waiting for heart failure transplant. But now we mainly depend on ICD to reduce the mortality, or a CRTD, which is used in addition to drug therapies, so that is device therapies can help. Next, we come to the aspect of preserved ejection fraction. This is an entity which has been discussed more in 2021, and this is very challenging to diagnose. And basically, due to stiffen and thickened chambers, occurs with a loss of diastolic function, and most importantly, it is very hardly well understood, and accounts for 30 to 40% of the heart failure patients. And it's basically because the heart muscles are thick and they cannot pump properly. Now, here you'll see in cases of diastolic heart failure, preserved ejection fraction, the heart function is more than 50%, the ejection fraction is maintained, so you are at a loss whether this patient is in heart failure or not. Again, most importantly, the Framingham study showed that if you see the red bars, you will see this is the bars of heart failure preserved ejection fraction. From 1985 to 2014, the incidence of preserved ejection fraction has increased over these 3 decades by 56%, from 41% to 56%. So this is alarming and calls that we should be recognizing these patients early. Same was shown in the Trivandrum heart failure study, that as years pass by, the mortality also increases from heart failure preserved ejection fraction. So we are trying to diagnose heart failure preserved ejection fraction as early as possible, so that we do not these patients do not land in heart failure. Now, there is a calculative score, the H2 HFpEF score, which is used there, the heavy body weight, hypertension, atrial fibrillation, pulmonary hypertension, elder, filling pressure. You put the patient a score of 0 to 9, higher is the score, more is the probability that your patient is in heart failure. This is how we calculate the patient, whether a patient is in heart failure, not having a normal ejection fraction. But if you see, they are mainly dependent on the echo-guided and certain clinical guidance. Now, this is a very remarkable study that was done. That is the Emperor Preserve study, which came out in 2021, which clearly stated that there was a 21% risk reduction if you put this patient, even non-diabetic patient or diabetic patients, if you put on empagliflozin, compared to fat-bile combination RNA or MRAs or irbesartan or perindopril or kindesartan. This clearly stated in 2021 that heart failure is preserved ejection fraction. Even if the patient is not a diabetic, you can put them on empagliflozin and they p-value was highly significant, and this showed that the maximum reduction was when you give an SGLT2 inhibitor. So now heart failure is preserved with reduced ejection fraction. Both these all, in whether the diabetes is present, they lead to cardiovascular death, hospitalization to heart failure is more. So we should recognize this entity of preserved ejection fraction as early as possible and just not wait till the patient comes to heart failure. One slide to just compare between preserved ejection fraction and reduced ejection fraction. You'll be surprised to see in diabetics, preserved ejection fraction is more than reduced ejection fraction. So most of the patient diabetics who have heart failure have a preserved ejection fraction. So this is an word of caution to all my physician and physician colleagues that try to check their biochemical parameters, their echo, to pick up this preserved ejection fraction diabetes so that they can be treated early and you can prevent hospitalization. This is something very interesting that these studies were on 39,982 patients from 254 hospitals showed an equal incidence preserved and reduced ejection fraction, and the mortality was almost similar. So let us not go with the idea that preserved ejection fraction has a better mortality than reduced ejection fraction compared to borderline ejection fraction. Reduced ejection fraction is equally bad, and preserved ejection fraction is equally bad as reduced ejection fraction so far as mortality is concerned. So in summary, heart failure is an early and forgotten complication diabetes, which all we have to worry about, because a patient of diabetes, when it comes with shortness of breath, easy fatigability, please think that your patient may be in heart failure. Number two, entity of heart failure preservation is more common in diabetics, as I have shown in the studies, and the outcomes are also very poor, as I have shown you from clinical evidence, and I've shown you from comparative studies of more than 40,000 patients. And echocardiography and biomarkers play an important role in diagnosis, and this is very important that any diabetic patient with the slightest doubt of heart failure have to go for a biochemical marker and an echocardiography. And lastly, SGLT2 inhibitors and ARNI are promising evidence-based drugs for managing heart failure in diabetes. So these are the certain take-home summary that one should realize. And most important is to realize that heart failure preserved ejection fraction is an entity which has come to stay, and we have our patients of reduced ejection fraction will gradually go to preserved ejection fraction if you put them on SGLT2 inhibitor and ARNI. And we have seen that if you put these patients on these two drugs, the incidence of use of devices have come down a lot. Thank you very much for your patient hearing.